Thank you so much, PK. It's great to be back in New York. It's great to be back at this meeting. It's been a terrific week. So a couple of years ago, a good friend and colleague of mine, Jeff Delaney, out at the Children's Hospital in Omaha, was pitching an idea for a new foreign body retrieval device. And what he had to say about these cases caught my attention. I thought it was quite good. He said his favorite kind of case to do is retrieval of a device that somebody else embolized. He said, in these cases, the best case scenario is you get the device and you're a hero, but even if you don't get it, the worst case is you made a heroic effort, and it's not your fault. He said, however, his least favorite case is retrieval of a device that he embolized. In this case, the very best case scenario is that you get the device, but all you did was clean up a mess that you created. And the worst case, well, maybe not quite as good. So rather than just call this case one, I've retitled this. I'm going to present two cases. One, which is the first one, which is the latter issue of a case where I had to go fishing for something that I had done, and the second where I had been called in to help a colleague who embolized the device. It may be shocking from a pediatric cardiologist to hear this kind of language. Typically, we're a little bit more tame. Do we have fellows here? Are there any fellows? Raise your hand. Yeah? Good. All right, I expect you guys to speak up here, and then we're going to call on you in just a little bit here. But it's important to remember that this happens to everybody, okay? Even when you're a young pup. And, you know, we're joined in the panel today by some real big dogs who know what they're doing, but it happens to the big dogs too. And if someday you want to become a big dog, you need to learn ways of cleaning up after yourself. So the details of this child's anatomy are not really important. This is an infant with hypoplastic left heart syndrome who underwent at 48 hours of age a hybrid stage 1 where we did, through a sternotomy, placed a PDA stent. And the main reason that I included this is just one of those nightmare patients where you just can't predict what's going to go wrong. And so the procedure went great, and as soon as we got him to the ICU, he had an unexplained arrest and he had to be resuscitated. At age 6 months, he had a stage 2 procedure, same thing. He did fine with the surgery and came back and arrested in the unit. He also had an IJ thrombus. And then I did some aortic arch interventions on him, and he had the worst pseudoaneurysm of my career. This was a subsequent case, and so because of that former pseudoaneurysm, I got left femoral arterial access rather than going through that old pseudoaneurysm. And what we found here were significant aortopulmonary collaterals. You could see all this flow going into these collaterals and then ending up coming back to the pulmonary veins, and this is a bad situation for this child's right ventricle, which is the systemic pump in this condition. So I went through the process of getting select angiograms and starting to include these, and I'd like one of the fellows to give me obviously I'm not done here. There's still work to be done, but I'd like one of the fellows to give me a grade on how I'm doing so far. A B? You're extremely generous, thank you. We have a real problem here, right? The most proximal coil is now sticking out into the subclavian artery, and I've got very little flow beyond there. So this has to come out. How? How are we going to do that? Any thoughts? How would you like to take this coil out? Snare, a lot of snares. I'm glad to hear that, and that was my choice. A lot of times people like the idea of using a bioptome. I think there are some advantages to a bioptome. They are readily available in almost every lab. They're simple and they're intuitive. You open and you close the jaws, and they're very quick to get control over a foreign body. However, they are difficult to steer. They are very stiff. You can't get a very firm grasp on something, and remember, these are designed to take a chunk of tissue out of someone, and you can obviously cause more harm than good. I opted to use a snare, which I think has the advantages of also being readily available. Very steerable, allowing firm control of the foreign body and also less likely to cause harm. But if you haven't used these very much, these can be deceptively tricky in terms of the mechanics and counterintuitive, and it requires practice. If you're in on a case where they use a snare, I recommend to the fellows that you wash it afterwards and keep it, or if there's an expired product, use it to practice. So one of my pearls here is the intuition is to grab an object from the front. If I had my cocktail sitting here and it started to tip over the edge, I would tend to reach out and grab it this way. I think this can oftentimes cause problems, and my recommendation is, not in every case, but frequently, to go beyond the foreign body that you're trying to capture and then come back over it. Here's kind of an example of what I mean by that. If this were in a vessel and we were advancing an open snare, we could easily push this further and further into a smaller and smaller vessel and make it harder to retrieve. Rather, I'd recommend going past the object prior to putting the snare out and then dragging it back over the object that you tend to retrieve. In addition, it's a little counterintuitive. Once you've worked very hard to get that loop of the snare over that small piece of foreign body, the tendency I think most of us have is to try and pull it like a lasso to tighten it. And if you do that, it's very likely that you will simply pull the snare off the object you've worked so hard to capture. Rather, it's really more of a advancement of the catheter and small adjustments keeping the snare in the same place. So that's what we did. We got past the coil, dragged it over, and missed. But eventually, we got what we intended, right? So we're done now, right? Well, not so much, right? It's one thing to grab the object, but removing it can be a very different thing. And so suddenly here you see that the coil has stopped advancing towards the sheath, and you can see that the catheter is starting to buckle on itself. So now what? We can't get it through the sheath. Go from the other side, and that's what I like about an endovascular crowd is you guys, that's like your first instinct. That's not so much for us. So grab objects from more than one direction. And so that's what we did. And I really didn't want to have to go back through that old pseudoaneurysm site, but I didn't think we had much choice. Taking some pictures to understand what's going on, we've got an issue here where the coil is really occluding the vessel, and the catheter that's the snare is going through is really blocking access for another snare. But since we've got control over it, we can manipulate the object that we want to try and grab. And then it's just a question of the old push-pull. At this point, it's important to make sure that you haven't caused any damage and you still have vessel patency, and then it was back to work. This was him post-operative day 0 from his initial hybrid procedure at Day of Life 2, and this was him in 2019. He actually, I just heard from his parents today that yesterday was his 13th birthday, so he's doing great. So the second case is a teenager who had a large secundum ASD, who had an Amplatzer placed in the hole and was persistently tachycardic overnight. This is suboptimal positioning. So here is the device overlying the mitral valve, and you see a large residual shunt, and probably the reason for the tachycardia is that there's relatively restricted mitral valve inflow. So what do you do here? Absolutely, you call the surgeon, and we're going to get back to that. In the meantime, what do? So while we're waiting for the surgical team to come in case we need them, actually, this wasn't me, this was my partner, and what he did was he used a bioptome, which I think in this case was a smart choice because it's quick. This is a big object, it's a moving object, and what the number one priority was initially was get this thing out of the left side of the heart. Less likely to cause systemic thromboembolism, less likely to end up covering the mitral valve, or worse, going through the mitral valve and into the LV. So that's what he did here. And so he's got a bioptome holding on to this device, and this is the point at which I was called to see if I could give him a hand. So now what? Surgeon's not there yet. So a snare can still be used, and now instead of having an object that's bouncing around in the left atrium, we have a relatively stable object. So we got access from the internal jugular, the right internal jugular, dropped down while we were holding the, with the bioptomes, the device, and snared the screw mechanism. Once again, it's not just a question of grabbing a hold of something. If you want to bring that fish in, you've got to land it the whole way. So this is kind of a mock-up of where the situation we're in, which is here's the catheter in the IJ. You can see that this pin isn't necessarily going to be accommodated by the sheath. So now what do? This is the situation where we couldn't pull it back up into the sheath from the IJ. Grab it from the other end. You guys are good. You get an A. So once again, grab it from more than one side. And if you do that, you can manipulate this object so that it's oriented more ideally for recapture. So that's what we did. From above, we had the snare. From below, we put the bioptome back in. And still, unfortunately, we couldn't quite orient it. So what do you do here? Well, you just pull really hard, right? That wasn't a great choice. Now, this is at the end of the case when we took this picture, that we still had a snare through there, but we could not pull this device through even with holding it from below because we still had that small amount that wasn't going through the sheath. So what else? Larger sheath, but it'd be tough to do. You'd have to let go of it with something, right? You could get it again, yeah, sure. Well, what we thought was, well, we still have one more place we could grab, which is right there. So we got vascular access from the opposite femoral vein, snared it, and then ended up being able to remove it from below. So the take-home messages I have in terms of removal of foreign bodies as complications is try to get a snare position distal to the body that you're trying to retrieve. Consider grabbing it from the opposite direction. Be cognizant while attempting to retrieve about vascular thrombosis and trauma that's possible. Assess your vascular patency during and after retrieval and treat as appropriately. And stock up and learn to use these different devices. Now, there are times where you think you can handle a situation no matter how big it is, but we can rapidly end up in over our heads. And this is the point that was made earlier. Call your surgeons early in the game, not once you're up to your neck. This is the team I played on in the 2015 U.S. Pond Hockey Championship in Minnesota, and this is really just to remind me, it's cliche, but medicine is a team sport, and Peter said it earlier. It's very clear participating in this symposium each year that this is particularly true, I think, when it comes to the endovascular work that you do. The relationships in pediatric interventional that we have with our surgical colleagues and their interventional radiologists, and like you guys have with the podiatrists as well, and with industry and the nurses and techs, is critical to what we do. I think potentially you can do it without having these strong multidisciplinary relationships, but I firmly believe that you can't do it well. Like I said, it really comes across being a part of this meeting. One last note I'll say is that everyone asked us the first day who exactly was stupid on the team, and we found out on day 2 when we were suiting up which one of the team members, I guess, got that moniker. Thanks very much.